Hi, everyone. My name is Sarah Sieper, and I'm the Knowledge Management and Strategic Communications Senior Associate on the Momentum Integrated Health Resilience Project funded by USAID. For the third episode of this series, we're going to focus on localization and partnerships in fragile settings to support improved family planning, reproductive health, and maternal newborn child health outcomes. Today, we have Shannon Prudhomme, Senior Partnerships Technical Advisor for Momentum, to discuss some of the ways the project is leveraging localization to help build transformative health resilience capacities and address fragility. Welcome, Shannon. Can you go ahead and introduce yourself and provide a brief introduction, specifically a little bit more about yourself and your role on the project?
Thank you for this opportunity, Sarah. I am delighted to talk about localization approaches within the project. As you mentioned, I am the Senior Technical Advisor for Partnerships. My background is in business development, project management, strategic partnerships, and private sector engagement. And for the MIHR project, my role focuses on providing leadership in developing and operationalizing the strategic vision for cross-sector collaborations and promoting principles of localization within the project, particularly to contribute to building health resilience. This includes providing technical assistance in partnerships planning, management, and reporting, as well as other features such as facilitating learning opportunities for country teams on locally relevant partnerships topics to contribute to building health resilient systems and advancing overall the health and well-being of communities where MER operates.
Thank you so much, Shannon, and welcome. I want you to first describe what the concept of localization is and how it's connected to the broader concept of health resilience. And can you also talk a little bit about the connection between these localization efforts and improved outcomes, particularly for the fragile settings like where Momentum works?
Sure. Localization actually refers to actions towards enabling and supporting the leadership of local actors, communities, and institutions, specifically to develop, manage, and monitor programs affecting them and the conditions affecting them. So this approach involves internal reforms aimed at strengthening local systems and enhancing responsiveness to local needs. And by focusing on local leadership and engagement, localization ensures that development outcomes are sustainable and maintained by communities themselves. Fragility, there's the fragility piece. Fragility specifically refers to the vulnerability and instability of a state, society, or system that makes it susceptible to crises and challenges. It often implies a lack of resilience and an inability to effectively respond to shocks, such as economic downturns, natural disasters, political instability, or even social unrest. It can manifest or present itself in various ways, including limited access to basic services, including health services, weak governance, poor infrastructure, and pervasive poverty. It's also characterized by a dysfunctional relationship between the state and civil society, or basically the absence or breakdown of the social contract between the people and their government. And this causes deficits of institutional capacity, such as limited health workers, electricity, other functions, and other areas of society that increases the risk of instability and violent conflict and other disruptive shocks. Localization specifically is a strategy to build transformative health resilience capacities to address fragility, including shocks and stresses in places where people may experience their government, primarily through healthcare delivery. Now, putting all that together, localization, fragility, also thinking about health resilience. Localization, as I mentioned previously, it's a strategy to build transformative health resilience. Within the context of health resilience, particularly in fragile settings where we operate, localization approaches improve the local health system's ability to respond to, recover from, and adapt to health-related shocks. It involves training and building the capacity of health workers and institutions, thus enhancing their ability to manage programs independently. And the increased local ownership leads to greater community engagement, effective public health measures, and better health outcomes, thereby ensuring that interventions are culturally appropriate and sustainable. Localization in the context of health systems specifically refers to the process of adapting health interventions and practices to fit the specific social, cultural, economic, and environmental conditions of a local area. This involves transferring more decision-making power and resources to local health authorities, communities, and organizations to design and implement health programs that are more relevant and effective for their specific context. This concept is deeply connected to health resilience. So trying to bring it all together, the way that it's connected to health resilience is the capacity of health systems to prepare for, respond, and recover from these adverse conditions while also maintaining essential functions. So in the midst of crises, also maintaining those essential functions. That's the health resilience piece. The connection between localization efforts and improved health outcomes is particularly significant in fragile settings, such as those where our project operates. In these environments, health systems are often weakened by conflict, instability, and/or limited resources. Localization can enhance health outcomes by, as mentioned previously, strengthening local capacity, increasing adaptability, and three, fostering partnerships. When you think of strengthening local capacity, strengthening the skills and resources of local health workers and facilities to ensure sustainability and a more resilient health infrastructure, increasing capacity. In fragile settings, the ability to quickly adapt to changing circumstances is vital. Local actors are often better positioned to make rapid decisions in response to health emergencies. And then that third piece, fostering partnerships. Localization encourages collaborations between local governments, NGOs, international partners, leading to more coordinated and effective health responses. So overall, localization is not just about improving the immediate health service delivery, it's also about building a very strong foundation for long-term health resilience that can withstand and adapt to future challenges.
Thank you so much for that really thorough response. Something that you mentioned throughout that a lot was capacity strengthening. And I know that our project has a capacity strengthening model that we use, which specifically has 6 key aspects. So I just want to learn a little bit more about that model and how they tie into localization as a concept.
Yes. Our capacity strengthening model actually aligns with our value-based partnerships principles that include three key areas. One, appreciative inquiry and intervention. Two, promotion of local leaders and locally owned enterprises. You hear the localization features again. And then three, support of local stakeholders in advancing solutions that they envision and design. And so the actual process, those are the three key principles of our value-based partnerships approach. But then we have the 6-part process, as you mentioned, that involves a continuous technical assistance, support, supervision, mentorship, coaching and training, monitoring and evaluation, planning and implementation of efficiency and quality improvement interventions approach. So all of those areas, those are the 6 parts. And I'll talk a little bit more about those 6 parts, but we use tailored tools and resources throughout the entire process of our capacity strengthening approach. So that first aspect, local partner engagement, consultations, and consensus. So the first step, we ensure that local voices are central from the outset, thereby fostering a participatory approach that's crucial for localization, especially. And by engaging our local partners and stakeholders in consultations and reaching consensus, we ensure that interventions are not only designed with local input, but also embraced by those who are directly impacted. And this aligns with localization by putting local actors at the forefront of decision making. It also helps to, in terms of our appreciative approach and inquiry approach, to ensure that we are looking at what works. We are looking at assets and foundations and resources that are working in the system. So it's a really forward-thinking, asset-focused approach rather than starting off thinking about deficits. So that's part one, local partner engagement, consultations, and consensus. And then part two is the joint capacity assessment. Collaboratively, we assess the capacities with local partners to identify both strengths and areas for improvement, ensuring that capacity strengthening is tailored to the actual needs and conditions on the ground. And this joint assessment process supports localization by valuing local knowledge and context, which are essential for designing effective and relevant interventions. And then three, prioritize capacity strengthening plan, the development of those plans. And we have an excellent capacity strengthening lead. We have a capacity strengthening partner on our consortium. That's wonderful. Through HAP. And so in terms of developing a prioritized capacity strengthening plan, this involves developing a plan that's based on the prioritized needs, prioritized by the local partner, those needs that have been identified through a participatory process that ensures that the plan is responsive to local conditions and represents the priorities that have been identified by the local partner who is proximate and or adjacent to the actual problems on a day-to-day basis. And this step exemplifies the localization principle of driving interventions based on local priorities and solutions envisioned by local stakeholders. And then four, implementing and monitoring a capacity strengthening plan. The implementation and ongoing monitoring of this plan allows for adaptive management and responsiveness to changing local conditions, which is a key element of localization. It ensures that interventions remain relevant and effective in the face of local dynamics and changes. Five, evaluate, document, and learn. So evaluation is critical, particularly for the understanding of the impact of capacity strengthening efforts and learning from them, learning what changes are needed, modifications, et cetera. So documenting successes and lessons learned promotes a culture of continuous improvement and knowledge sharing among local partners and stakeholders, reinforcing the localization principle of developing local capacities and learning systems. And then finally, six, partner capacity reassessment. Reassessing the capacity of partners after interventions have been implemented allows for the measurement of progress and identification of new areas for improvement. This cyclical process ensures sustainable capacity strengthening, which is fundamental to localization, as it ensures that local systems and partners continually evolve and are strengthened and supported. And this approach not only fosters local ownership and capacity, but it also aligns with the broader global development goals that emphasize the importance of locally led development and long-term impact and resilience.
Thank you so much for diving into those sort of six key steps. So I know our project leverages these approaches across the project, and they vary based on country context. I know you have several examples that you want to discuss with us today, sort of about the practical application of these localization approaches, including stories from Mali and South Sudan. So do you want to start off by describing how our project is prioritizing localization in Mali?
Sure, I'd be glad to. Our work in Mali is actually a great example, as well as South Sudan. They're both great examples of how we have integrated localization approaches into our work. In Mali specifically, it's a great example, particularly in the areas of engagement and inclusion of local leaders, as well as civil society stakeholders. We have a framework for exchange between our Mali team and local leaders. So these leaders and civil society organizations participate actively in the planning of MIHR's work plan and activities. So they define their priorities in line with our project's objectives. So remember, we talked about localization and a breakdown between the state and civil society. And this is the work we are doing to sort of address that. And so, for example, the regional health department and the health district are involved in drawing up the terms of reference for the activities that involve them, and they participate fully in the project's annual review, which is an opportunity to assess the project's contribution, and they can make recommendations for continuous improvement of the results and how they can be involved and how we can support them. Our Mali team also started the engagement process from scoping by identifying the essential stakeholders in the implementation of the project, who are the key local actors that we need to engage. And during the scoping, we showed local and national authorities that the project supports them in responding to the health priorities of women and their partners, girls, and children. Our co-creation process in each of our areas of intervention discussed activities and strategies and having a common understanding of the project. This involved specifically a 2-day workshop. And during that workshop, all of the stakeholders at the local level were invited: government structures, civil society, private structures, community health associations, healthcare providers, and other technical and financial partners intervening in the area, bringing back that concept of value-based partnerships and cross-sector partnerships. The roles and responsibilities of each stakeholder were identified, collaboration framework was developed, and the coordination mechanisms were established. That was at the beginning of the project. And all of this was materialized into a commitment document that has been signed by each stakeholder. So it took a bit of work. It took a workshop to convene these partners, took some mapping, but that is how we have worked and engaged local leadership, specifically in Mali. And in our work plan specifically, we schedule semi-annual and annual activities and updates on the commitments that were discussed, keeping that social contract, maintaining it and supporting it. And also during the annual sessions of presentation of the reports and annual planning that's organized actually by the Ministry of Health in each region, our MIHR project team accompanies this process so that there is an alignment of our support, not leadership, but support within the objectives of the Ministry of Health. So, for example, in the selection of local NGOs that we want to engage or partner with, the activities have been discussed with the health district to see what support local NGOs can provide in the supply and demand of health services at the community level. We have a couple more examples in Mali that exemplify this as well. So, thinking about engagement of local leadership again, in Timbuktu and in Gao, we have some examples. In Timbuktu, we've supported the filling of human resources gap in Sankore Health Facility. MIHR made a tripartite MOU with the district. We've established that, and the Community Health Association managing the health facility. The Community Health Association was made responsible for recruiting the doctor, their leadership, their identification and support in recruitment, and we provided financial support for the payment of the salary and continue to through funds transferred to the association's account. And for a 3-year period of the MOU, the project has paid 100% in the first year, the second year, 75%, and in the third year, 50%. So that cascading, so that the association then takes over completely from the fourth year moving forward of funding for that position. So thinking about sustainability and resilience building, we've supported for 3 years. It's understood through an agreement what that process would look like, and it's cascaded year by year over the course of 3 years, with the fourth year being a full transfer to the community association. That's in Timbuktu. In Gao, the Village Solidarity Fund was established through the support of our projects. And 6 of the 10 health areas have set up their village solidarity funds, as well as fund management and monitoring committees. And so the method of resource mobilization established by these 6 health areas was the annual flat rate contribution of 500 to 600 francs per household, and the overall amount mobilized was 1.4 francs as of February 2024. Community mobilized and engaged in their contributions to create a solidarity fund. And these funds collected have been used to ensure the transport of pregnant women experiencing childbirth difficulties um, from uh, from certain areas to the reference health center. In total, 10 pregnant women have benefited from this assistance so far. Among them, 4 were referred from villages to other areas, and the other 6 were evacuated from specific areas to Gao. Thanks to these solidarity funds, all these pregnant women and their children were able to be saved. So we have actually 3 examples from Mali. So now I'd like to touch on South Sudan. South Sudan really exemplifies how we partner, our emphasis on that specific area of MIHR's partnerships approach. So we work in fragile settings, and we are thoughtful about not only who we partner, but how we partner with them, how we contribute and also enable local leadership and ownership of this work. So in South Sudan specifically, one of our strategies for contributing to resilience building is through the strengthening of the health workforce. We know in some countries, including South Sudan, there's chronic underinvestment in the health workforce. There aren't really sufficient hiring mechanisms. There's significant shortages in rural areas. There's also connectivity issues, infrastructure issues, et cetera. So thinking about how we partner and who we partner with is important. So, specific to the health workforce and strengthening of the health workforce, there are certain key factors that we have considered in determining how we could effectively partner with local institutions for this work, as well as which local institutions would contribute to achieving sustainable health outcomes. I want to hone in on the Midwifery Association that we partner with in South Sudan, but I'll also talk about how we also supported capacity strengthening across different health workers, and then delve a bit more deeply into our specific partnership with the Midwifery Association. So currently in South Sudan has the highest rate of newborn and maternal mortality globally. The country's leading cause of death among women is complications during pregnancy and childbirth. And only 1 in 5 births involves a skilled health worker. In addition, the shortage of skilled health workers is essentially acute in South Sudan. And there are infrastructure challenges in terms of electricity, internet connectivity, as I stated previously, specifically. And these are considerations that have been important in our partnerships approach. We've thought about how do we provide capacity strengthening technical assistance without removing critical health workers from facilities that are already strained for an extended period of time. How do we do that? And limit the amount of time we remove them from those health facilities. It's critical, it's vital to consider that. So, one of our strategic partners, for example, is the South Sudan Nurses and Midwives Association, or SANAMA. And we have partnered with them in a manner that considers the limited resources for health in the country, as well as the infrastructure needs. Globally, evidence has demonstrated that midwives have been shown to provide vital contributions during various humanitarian crises, such as mitigating disruptions in sexual, reproductive, maternal, newborn, and adolescent health services. In South Sudan, we have provided capacity strengthening training as well as engaged Sanama as an implementing partner to provide supervision and mentorship to our supported health facilities. When it comes to the capacity strengthening component in South Sudan, there are human cause issues. As we mentioned, limited infrastructure, certain challenges with communication platforms. And then we have the natural hazards such as floods, droughts, insects that present challenges for designing and implementing training, mentorship, and related programs designed to develop health worker skills. So think traveling for health workers to participate in capacity strengthening training programs, all of those things, connectivity issues, being able to connect from home, et cetera. So all these considerations, not only who to partner, but how we partner, we considered as we were developing this partnership and determining how we could significantly invest in health workers in the country. And so the current training approach was designed around the low dose, high frequency concept. And this is a concept that promotes short, targeted, in-service simulation-based learning activities that are spaced over time and reinforced with structured, ongoing workplace practice sessions. So we customized it a bit given the infrastructure challenges within South Sudan. What did this training look like? How did we integrate these considerations into the training approach? Well, the training participants, all of whom were in person for a short period of time before we continued on with the spaced out, short targeted continuation mentorship after the in-person training. But for a short period, and while I'll explain more, the training participants who are in person included 6 Momentum team members, 2 of our MNH leads, our child health advisor, 1 family planning officer, 1 family planning specialist, and 1 monitoring and evaluation officer. That was our MIHR team. We also included 3 midwives from 3 project supported health facilities, and then 5 representatives from SANAMA, the South Sudan Nurses and Midwives Association, 4 county health department reproductive health officers, 1 obstetrician gynecologist from the Association of Gynecologists and Obstetricians of South Sudan, or AGOS, 1 pediatrician from the South Sudan Pediatric Association, and 1 medical doctor from the Ministry of Health. So several health professionals, a few health associations, we involve members from those health associations and our health facilities, as well as some of our MIHR team members. And the in-person training specifically was designed as a training of trainers for health workers who would then function and cascade that knowledge down by serving as mentors and trainers to train health providers in their respective facilities. These partners were targeted for the training as relevant candidates for contributing specifically to absorptive and adaptive health resilience capacities. So we had a 3-day immersive in-person component of the training in Juba. The training was hosted in January 2023. It focused on clinical course content, skills demonstrations that were delivered by trained global mentors on neonatal resuscitation. We had experts in that area, skills practice among participants, and we had performance feedback that was provided by local facilitators and the global mentors in large and small groups. This was followed by 2 days of practical sessions at a health facility where our newly trained providers were able to provide a demonstration using the emergency newborn care curriculum, which was the focus of the training that was delivered to them. And then follow-up mentoring and coaching was continued for several months through the use of a phone messaging application to support cross-learning among health workers. So health workers who participated in the training working at different facilities were able to cross-train, share their knowledge, support corrective action and learning with the support of global mentors through a phone application. So in terms of integrated localization and resilience building approaches, the training program and our partnership with SANAMA, specifically, the South Sudan Nurses and Midwives Association, has aimed to address absorptive capacities through the promotion of what we call redundancy in essential newborn care service delivery functions and resources among health workers. Redundancy. It's actually a determinant factor for health system resilience. It specifically refers to having a sufficient number and capacity of actors who carry out any system functions that may become disabled due to shocks or stresses. So thinking about emergency newborn care and specifically newborn resuscitation, this is a redundancy that we have aimed to support and contribute to through this training and also the subsequent engagement and partnership with Sanama, which has continued in our project.
Thank you so much for sharing those examples from Mali and South Sudan. It was very insightful. So now that we've really talked about the work that's being done, I kind of want to focus on measurement. So how are we evaluating the impact of these different localization efforts that we're doing across the project?
We have, through our capacity strengthening team, as well as our monitoring and evaluation team, we have certain indicators that measure localization related areas, such as our capacity strengthening and social accountability indicators. We also have other indicators in the areas of partnerships and some other areas, but a couple of our key areas are capacity strengthening and social accountability. So for capacity strengthening, we measure specifically the number or percentage of project supported organizations with improved performance on an annual basis using a customized organizational performance index, or OPI, tool that measures the organizational areas of achievement of results, including the improvement of service delivery efficiencies, participatory processes and adaptive learning mechanisms, sustainability in terms of financial resources, and establish resource mobilization plans, and resilience evidenced by stakeholder maps and relationships with key stakeholders. So there's cross-section of areas that really demonstrate are included in an organizational performance index that we use that's customized specifically for fragile contexts in our work on resilience building. And then another area, as I mentioned, that we measure as it relates to social accountability is elevating the use of local data. So specifically, in terms of social accountability and resilience building, our resilience team has developed an analysis of resilience of communities to disaster. We call them the ARC-D health tools. Again, analysis of resilience of communities to disaster for health tools, which is a qualitative participatory resilience analysis methodology. We measure, and specifically with that tool, the ARC-D health tools, we measure the number or percentage of communities supported by the project with improved ARC-D health areas and other standard community health resilience tool scores. So customized indicators that are included within that tool that are intended to measure resilience, and social accountability is included in that tool.
Thank you so much for that. I want to end our interview with this question. So, for global health professionals out there or those working in adjacent fields who are really looking to prioritize localization, capacity building, and resilience efforts into their work, where should they start? Websites to visit, resources to review, trainings that they could participate in, things of that nature.
Several resources. I'd recommend a few key ones. Thinking about three key areas: localization, of course, capacity strengthening and resilience. For localization, USAID has great resources on different areas of localization. One of them is the USAID Good Practices for Local Leadership, and it's which is integrated actually into the locally led programs indicator. Humentum is a training organization in our industry that has resources that are on demand and recorded that focus on operationalizing locally led development with specialists across the industry. And that's available on their website. They present topics, these specialists, around localization and locally led development. Then there's capacity strengthening resources. You can review resources provided by the World Health Organization. They have guidance on capacity strengthening for health system strengthening specifically, and including workforce development and governance, those areas of localization. Also, USAID's Capacity Plus project has a knowledge library with great resources. And then finally, the third piece, resilience. The Global Resilience Partnership has online courses and guidance on applying resilience principles across sectors, including health. And I just want to emphasize that the key is leveraging existing knowledge from global organizations while adapting approaches to fit the local context through stakeholder engagement and cultural understanding. Continuous learning, collaboration, and knowledge sharing are vital to effective localization and resilience building efforts. So, hopefully, these resources I shared are helpful to you and can help you grow in your journey as you aim to implement and expand localization in the work that you do.
Thank you so much, Shannon, for your insight and for sharing your knowledge on why prioritizing localization is really essential for helping to strengthen health resilience and improve health outcomes in our partner countries.
Thank you.